So the article chosen today is the one in JAMA, showing the use of alteplase in ischemic stroke beyond 9 hours, beyond 4.5 hours, extending up to 24 hours. Dr. Hari will be appraising this article. Over to you, Hari.
Thank you, ma'am. Good evening, everyone. Today we are going to discuss about thrombolysis in acute ischemic stroke. This was a pragmatic trial which was published in JAMA on August 7, 2025. Before going into trial, I'm just going to give a small introduction about stroke and stroke guidelines. There were two modalities which were the cornerstone for in acute ischemic stroke, which is one is mechanical thrombectomy and another one is intravenous thrombolysis. The American Stroke Association, American Heart Association, European Stroke Guidelines were have approved thrombolysis until 4.5 years. And the recent trials, which was published in 2018, extent has
gentle request to off your microphones, please. Other than speaker, everybody, please. Other than speaker, everybody else, please mute your microphones. Thank you very much. Hari, continue.
The recent trials have showed more than 4.5 years, we can use the thrombolysis with the advanced imaging modalities. European stroke guidelines have approved it, the use of alteplase or tenecteplase up to 9 hours. So, going into the guidelines of AH and AIC, the guidelines for stroke is the same as 4.5 years. It was approved by American Heart Association and European guidelines. The most common cause of ischemic stroke is 80 to 85% of the strokes were acute ischemic stroke, and remaining 20% is hemorrhagic. And in that ischemic stroke, 50% of the ischemic stroke accounts for large vessel occlusion or atherosclerotic infarction. Lacunar infarct approximates around 25%, and 15% of cardioembolic infarct. And vasculitides and blood disorders contribute around 5% each. Going into the penumbra, penumbra refers to the area of brain tissue surrounding the ischemic core. Ischemic core is the place where the brain tissue is irreversibly damaged. The penumbra can survive for several hours, depending upon the collateral circulation for each patient. Salvaging the penumbra is the main goal in acute ischemic stroke therapy. At 60 minutes, about 90% of the penumbra will be salvageable. Over the period at 2 hours, it will be around 80, 3 hours, it will be 60%, and around 4.5 hours, it will be around 40%, and 9 hours, 30, and 12 hours, the salvageable penumbra will be less than 20%. Non-contrast CT is the primary modality in ischemic stroke. It helps in differentiating ischemic stroke from hemorrhagic and excludes stroke mimics, tumors, seizures, and estimate the presence and extent of salvageable tissue. The CT perfusion and CT angio will be helpful in estimate the presence and extent of salvageable tissue. And CT angiogram will be helping in the findings of occluded artery in ischemic stroke and to help treatment planning. MRI is MRI is comparatively superior compared to CT in hyperacute and acute phases. Diffuse weighted imaging is the best sequence to detect ischemic core within minutes after onset, and DWI flare mismatch will be helpful in identifying the time period of stroke in unknown time of stroke onset or wake up stroke. The DWI flare mismatch will be helping in finding out the time interval. The thrombolysis, coming to thrombolysis, we are using tissue recombinant plasminogen activator, which will be acting on plasminogen, which will convert plasmin to and break down fibrin mesh, which causes clot lysis and recanalization. The efficacy of these agents depends upon the age of clot, size, and location. NINS and ECAS trial had proven the benefit for recombinant tissue plasminogen activator in acute ischemic stroke within 3 years, in which NINS trial was done in 1995, published in NEJM, and ECAS 1 was also in 1995 in European Journal of Neurology. ECAS 3 came in 2008, and Atlantis A-B, which was published in JAMA in 2000, IST3 and Epithet trial, Lancet. Epithet was published in JAMA in 2008. And these trials have proven benefit of recombinant tissue plasminogen activator in acute ischemic stroke within 3 years. ECAS 3 trial showed the benefit of thrombolysis with altiplase in patients with clearly defined symptoms onset between 3 to 4.5 hours of stroke onset. However, the FDA has approved altiplase for thrombolysis only up to 3 hours. And thrombolytic therapy beyond 4.5 hours was not found beneficial in 3 trials: Atlantis A, B, and IST3 and Epithet. The Wake Up trial was published came in 2018, which used MRI guided thrombolysis for stroke with unknown time of onset. It was multi-center randomized double-blinded placebo-controlled trial. One group was obtaining altiplase and another one was placebo. In patients with acute ischemic stroke with unknown time of onset, IV altiplase resulted in significantly better functional outcome and numerically more intracranial hemorrhages than placebo at 90 days. Despite the clinical benefit, altiplase, the infarct volume on MRI at 22 and 36 hours was not significantly different between 2 trial groups. And logarithm for patient with suspected stroke, if patient is if presented with less than 4.5 hours, CT or CT angiogram. In CT angio, if large vessel occlusion is absent, we can go ahead with thrombolysis, and large vessel occlusion is present, chemical thrombolysis and mechanical thrombectomy will be helpful. If it is more than 4.5 hours, CT or CT angio and CT perfusion can be done if it is more than 6 hours. If large vessel occlusion is present, we can go ahead with mechanical thrombectomy. In large vessel occlusion absent, we can go ahead with MRI and diffuse flare mismatch and thrombolysis. It was concluded from Wake Up trial, and extending the window period for thrombolysis, ECAS 4 tested the hypothesis that acute ischemic stroke patients with significant penumbral mismatch at 4.5 to 9 hours after onset of stroke or wake up stroke will have better clinical outcome compared to placebo. This trial was, the planned sample size was 264. The trial was underpowered, and hence strong conclusions cannot be made out of these results. This trial was stopped early after recruiting 120 patients due to slow recruitment, and many were eligible for mechanical thrombectomy. This was the trial timeline of major strokes.
Hari,
Ma'am?
So on this background, what was
Okay,
the
ma'am.
need for this study? And let's begin with the study.
Ma'am, extending the time period of intravenous thrombolysis in a resource limited setting is the main thing of this study, ma'am.
So what was the difference between the acronym for this trial is HOPE trial? What was the difference between HOPE and the one you're showing now?
Ma'am, from Hope trial you are asking, ma'am?
The one you're going to present is also
Yes,
called
ma'am.
HOPE trial.
Yeah, ma'am.
So why was HOPE trial done when this the presently what you're talking about, when this
Yeah,
trial
ma'am.
was already here, what was the need to do the HOPE trial?
Ma'am, this trial was done up to 9 hours only, ma'am. This extend wake up trial, these things and all was done up to 9 hours from the stroke onset up to 9 hours it was done, ma'am. The Hope trial was done uh, uh, other than large vessel occlusion or that small vessel occlusion, not only large vessel, ma'am, middle cerebral or internal carotid, everything it was covered in Hope trial and extending the time period up to 24 hours.
Yeah, so basically, this trial is looking at ischemic stroke involving smaller vessels, but thrombectomy is not to be considered.
Yeah, ma'am.
Thrombectomy is the standard of care for large vessel
Large
occlusion.
vessel.
There's no doubt about it. Beyond large vessel occlusion, the smaller vessels, is there a point of IV thrombolysis for an extended period of time beyond 4.5 hours to 24 hours? That is the question this trial or HOPE trial is trying to study. So let's go on with the study, please.
Over decades, intravenous thrombolysis has been the cornerstone of ischemic stroke reperfusion therapy. The standard therapeutic window was up to 4.5 hours, as we discussed before, and it involves the clinical and non-contrast CT criteria to identify the patients who are candidates for intravenous thrombolysis. The expansion in time from 3 to 4 hours after onset increased the pool of potentially eligible patients by 30%. And I'm just giving a brief introduction about the past trials, which was
I think
published.
you can skip this. You've already talked about it.
Yeah, ma'am. Ma'am, regarding timeless trace 3, ma'am, going into the study, to evaluate the safety and efficacy of intravenous altiplase administered 4.5 to 24 hours after stroke onset in patients with salvageable brain tissue, regardless of presence of large vessel occlusion. The study design, it was randomized, open labeled, blinded endpoint trial. The enrollment period was from June 2021 to June 2024. Data were analyzed from December 2024 to February 2025. Follow-up period was 90 days for primary outcome and 36 hours for safety outcomes. And it was conducted in 26 centers across China. The sample size was around 372 patients. Statistical analysis was done. Primary outcome by modified Poisson regression and secondary outcome by ordinal logistic regression.
Okay, so if it is a open, just go to the previous slide. Yeah. If it is an open label, how is it blinded? What do you mean by open label blinded?
Ma'am, only the accesses and the investigators, ma'am. It was divided into two groups, and the endpoint result was blinded to the investigators, ma'am.
Correct. The people who were looking at the results were blinded to the two arms, but while the study was being carried out, there was nothing like when you were giving PP as an infusion, the syringe was covered and some equivalent another drug was being given, nothing of that. So it was open label. But the people who were analyzing the results were blinded to it.
It was a partially blinded study, ma'am.
No, it was not. Investigator blinded.
Yeah, investigator alone is blinded, ma'am. neither the patient nor the treating physician,
Yes,
they were not blinded, ma'am.
correct. Carry on.
Once the stroke onset was more than 4.5 hours, CT perfusion was done on the eligible patients. CT perfusion confirmed salvageable penumbra, core less than or equal to 70 ml, and penumbra more than 10 ml. Mismatch is more than or equal to 20%. The patients who are receiving mechanical thrombectomy were excluded from this, and randomization was done 1:1. The 1:1 ratio who receive recombinant tissue plasminogen activator and control group. Clinical assessment was done in 24 hours with the NIHS score, and within 24 hours CT and or MRI diffuse phase imaging was done to see any hemorrhagic transformation was there, and 7 days NIHS score was also calculated, and follow-up in 90 days the MRS score was calculated between two groups and it was compared. The eligibility criteria: patients were 18 years or older, and the NIHS score was around 4 to 26. Pre-stroke score of 0 or 1 on MRS. Salvageable tissue and CT perfusion imaging was done. Exclusion criteria: thrombectomy was planned at the time of randomization. Guideline-based contraindication to alteplase. Totally 3,885 adults were.
Just wait, Hariprasad. So till the last slide,
Okay,
in
ma'am.
the design of the study, what are the strong points of the study compared to others?
Ma'am, the previous trials, one trial was done along with thrombectomy and intravascular lysis, ma'am. Some studies were done compared both the mechanical thrombectomy and thrombolysis was done in some trials, and only large vessel occlusion patients were done, ma'am.
Okay. How did you choose this eligibility criteria? How is this study more pragmatic compared to others? So, like you said, in previous studies, the study arm has received two therapies. Intravenous thrombolysis along with thrombectomy. Here we have excluded thrombectomy arm, taken off the large vessel occlusion, and we are only looking at the medium and small vessel occlusion. Second thing is, we are only looking at intravascular thrombolysis, no thrombectomy. Most pragmatic thing is the CT perfusion imaging. In the other studies, they have looked at a more advanced radiological imaging, and they have tools which were commercial and needed a lot of money to get. So as far as we are concerned, NMICs are concerned, CT perfusion is within our reach. So this is very pragmatic and more applicable compared to other studies. That is one of the plus points of the design of the study. Okay.
Ma'am, like 36% of the population had distal occlusions, ma'am. The rest of the people had a large vessel occlusions, ma'am. I think they have given an option of mechanical thrombectomy for all the patients who had a criteria satisfied for mechanical thrombectomy. But those who have deferred for mechanical thrombectomy, I think they have included in this trial, ma'am.
So there is no patient who has received both. The patients included in the study are those not considered thrombectomy.
Ma'am, your network is not clear, ma'am.
This study, there is no patient who has received both lysis and thrombectomy. Even if they were eligible for thrombectomy, they have denied that option and only received lysis. Both mode of treatment has not been done.
Yes, ma'am.
You explain this flow chart, that will make it more clear.
Yeah, ma'am. totally 3,885 adults with acute stroke with symptom onset time within 4.5 to 24 hours assessed for eligibility. In that, 3,513 were excluded because of 1,946 NIHS score were less than 4 or more than 26. 753 intended to receive endovascular therapy, and 428 were they were having acute or post intracerebral hemorrhage, and 119 patients received thrombolytic at an external hospital, and 83 refused to participate in the trial. 73 did not meet target mismatch profile on CT perfusion. 41 hypodensity in more than one third of MCA territory on non-contrast CT. 27 ischemic stroke or myocardial infarction in previous 3 months, and 21 unable to perform or uninterpretable CT perfusion. 12 any known impairment in coagulation. 10 were presented with sugars less than 2.8 or more than 22.2 millimoles per liter. From that, 372 patients were randomized, 186 to Altiplase group and 186 to standard medical treatment group. 182 received intervention as randomized. 4 did not receive intervention as randomized because 3 excluded. 2 received rescue thrombectomy and 1 enrolled inappropriately because infarct size is more than one third of MCA territory. 186 was randomized to standard medical treatment group. In that, 182 received intervention as randomized. 4 did not receive intervention as randomized. In standard group, 11 were excluded because 7 received rescue thrombectomy, 4 enrolled inappropriately because of infarct size is more than one third of MCA territory category, and 1 was ischemic stroke in previous 3 months. In that, 186 included in primary analysis, 179 was included in per protocol analysis. In this, 171 was included in per protocol analysis. The groups were divided into Altiplase and standard group. The standard group received antiplatelet therapy and other supportive care based on same guideline. Altiplase group received IV Altiplase at 0.9 mg per kg, maximum up to 90 mg, with 10% administered as a bolus over 1 minute, followed by a 60-minute infusion of remaining dose. After 24 hours, received standard post-stroke care, including antiplatelet therapy if indicated. The primary outcome, the percentage of patients achieving non-disabled functional outcome defined as MRS score of 0 to 1 at 90 days. And secondary outcome, the percentage of patients achieving independent recovery defined as MRS score of 0 to 2 at 90 days. The proportion of patients achieving MRS score of 0 to 3 at 90 days. The ordinal distribution of MRS at 90 days, major neurological improvement defined as an improvement of at least 8 points on NIHS compared with initial deficit, or a score of less than 1 achieved at 24 hours and 7 days. This was the screening and pre-thrombolysis, the consent demographic data, MRS score, NIHS, symptoms of disease, medical history, everything was collected. And before intravenous thrombolysis, NIHS score was calculated, and 24 to 36 hours NIHS score was calculated, and day 7 NIHS score, and day 90 plus or minus 7 days MRS score was calculated. And the medications, vital signs, everything was measured at the same intervals. The imaging was done at initial presentation and at 24 to 36 hours. And if needed, 5 to 7 days. And the adverse events were assessed. The baseline characteristics in the full analysis that the median age was around 72, and predominantly male patients were there in both Altiplase and standard group, and hypertension was there in 70% of the people in Altiplase and standard medical treatment. Coming to now, and the NIHS MRS score before stroke it was 0 in 177 patients and 172 patients in standard group, and one MRS score of 1 was there in 9 patients in Altiplace group and 14 patients in standard group. NIHS score at randomization was done, and it was less than 10 in 91 patients and 89 patients, more than or equal to 10 in 95 patients and 97 patients. The answer to imaging time, everything was more or less similar.
What does it suggest, Hari? Like NHS score at, see, both the parameters, all the parameters are well matched, right? If you happen to see both in the intervention arm and the control arm are
Yes, sir.
well matched, which is very essential to compare the outcome of the study, right? Okay. So what does this NHS less than 10 means? So it is roughly 50% of the population had less than 10, and 50% population had an NHS score of more than 10.
Yes, sir. Yes, sir. That is around 48.9, sir, and it was more than 10 is 51%, sir.
Oh, so see, it's almost like 50% population had a
50%,
moderate
yes.
stroke, while 50% population had a severe stroke. Right? Okay.
Yes, sir.
The median age was 70s, right?
72, sir.
Okay. Who were predominant, male or females?
Sir, male, sir.
60% were close to 55 to 60% were males, right? Okay. Okay,
And
ma'am.
the door to needle time.
Yeah, tell me, ma'am. Sorry.
Sir, yes, sir. And the door to needle time in Altiplace group was around 66 minutes, sir.
Okay.
Baseline aspects were also matched, and the ischemic core was also, and perfusion imaging, everything was more or less same in both the groups, sir.
So the core volume is like 12 ml, right?
Yes, sir.
Median volume is 12 ml, 12 to 14
Yes,
ml.
Yes, sir.
Okay. The requirement was? No, during randomization, during enrollment for eligibility criteria, you said the core volume should be less than or equal to?
The core volume should be less than or equal to 70 ml, sir.
70 ml, ma. And
Yes,
your
sir.
penumbra should be?
Sir, the penumbra should be less than 10 ml, sir.
More than 10 ml, ma.
More than 10 ml. Yes, sir.
You said the mismatch should be getting more than 20%, right?
Yes, sir.
The ratio should be getting above 1.2. No, does this satisfy the criteria, ma, for the eligibility criteria?
Yes, sir.
It's quite significant, right? If you happen to see the core volume is hardly, 12 to 15, 14, while the penumbra zone is close to 50 ml. It's almost like 4 times the core volume, right? The ratio is almost 4, right? It's more than 1.2. So there was a significant amount of penumbra zone, salvageable brain, right? Okay.
Yes, sir.
Okay, ma'am. So how many of them had a unwitnessed onset or stroke on awakening?
Sir, 76%, 76 patients was having in Altiplace, and 73 patients in standard group, sir.
No, almost 50% of the population had a stroke on, unwitnessed onset and stroke on awakening.
Yes,
The remaining 50%, they had a defined stroke onset type.
Yes, sir.
So,
Okay.
Hari Prasad, for the unknown time, how did they divide it into less than 9 hours or more than 9 hours?
Ma'am, last known normal and presentation, the midpoint they have taken, ma'am.
Yeah, so that definition is also not very commonly used. That was also a very nice point in this trial. So they were able, based on that definition, they were able to dichotomize into fixed time periods. Okay. Similarly, worsening. How have they defined worsening?
Ma'am, within 24 hours, by seeing the NIHS score and CT imaging was done, ma'am.
NIH's score, how have they defined? Improvement and worsening both have been defined.
Yeah, ma'am.
How?
Ma'am, in 24 hours, the NIHS score should be less than 1, ma'am. If the score is 10, in 24 hours, the score is reduced to 9, it is considered as improvement, ma'am.
Yeah, improvement by 8 points.
Yeah,
Whereas worsening is NIH's score increases by 4
Uh,
points.
yeah, ma'am.
So worsening has been given more importance than improving. So that is also again a very pragmatic. As well as a primary objective, you see MRS of 0 to 1. That is like
Yeah,
someone who's left with no residue at all.
yes,
Very
ma'am.
functional. There is no stigma of this stroke at all. It's a very usually in TPI and all. What is the MRS we use? 0 to 3.
Yeah,
Here,
ma'am.
0 to 2 and 0 to 3 is a secondary objective. Primary is 0 to 1. So these points are what makes this trial very, very pragmatic. Carry on.
Yeah. Trial outcomes in full analysis and MRS score 0 to 1 at 90 days. In Altiplase group, it was around 40%, and standard medical treatment, it was around 26.3%. The p value is 0.004, which was significant. And symptomatic intracranial hemorrhage within 36 hours was also little bit high in Altiplase group. It was around 7 patients, and standard medical treatment, it was around 1. P value is around 0.01. Remaining the secondary outcomes, distribution of MRS score at 90 days, it was around 0 for 41 patients, and in Altiplase and standard treatment, it was around 25, and one was around 34 patients, and 24 patients were in standard medical group. And 3 patients were MRS score of 3 in 17 patients in Altiplase, and 29 patients in a standard treatment group, and 4 patients. So MRS score of 4 in 27 patients and 28 patients in standard group. 6 MRS score of 6 was same, more or less same. 6 is death at 90 days was 20 patients in Altiplase and standard medical treatment. There was no significant mortality benefit in both the Altiplase and standard medical group. Major neurological improvement at 24 hours was significantly better in Altiplase group, which was 39, and in standard medical treatment, it was around 24. Major neurological improvement at 7 days, it was around 65 patients were having more improvement, and compared to standard medical group, it was around 50 patients. As we discussed before, it was around the same, and intracranial hemorrhage was little bit high, and parenchymal hematoma within 36 hours was around 14 patients in Altiplase group and 6 patients in standard medical treatment group.
So Hariprasad, this
Uh,
ICH that happened,
Yes,
how
ma'am.
did it required evacuation? What was the effect of the ICH on the patients?
Ma'am,
You said the incidence of ICH was greater in the treatment arm.
Altiplase group, ma'am. Yeah, ma'am.
Yeah. But what was the net result of it? It did not increase mortality nor the functional outcome.
Yeah, ma'am.
It is only radiologically proven ICH which was increased. I mean, which caused the increase in the treatment arm, but it did not affect functionally.
Yeah.
Carry on.
And distribution of modified Rankin scale scores at 90 days. The primary analysis and per protocol analysis, and it was standard medical treatment group and the Altiplase treatment group. The MR score was higher, which indicates MR score was 0 in Altiplase group. It was around 0 and 1. All the subgroups, the MR score was little bit better in compared to Altiplase and standard medical treatment. And in protocol analysis, also in altiplase, it was little bit higher compared to standard medical treatment. Uh, in subgroup analysis, the primary outcome and in the primary outcome with the MRS score are 0 or 1 at 90 days. Overall, altiplase groups have better MRS scores. The median age, male, and the NIH score were already discussed. The occlusion site where it was the internal carotid artery.
Don't run away with this. Wait, pause, and do. So look at where all has this been more beneficial. Can you make any conclusive comment about age more than 80?
Ma'am, in altiplase groups,
Look at the forest plot and answer no. The confidence interval is so wide, you cannot tell. The numbers in above 80 age group is very few. So you cannot conclusively say that Altiplase did a better job in that group. Very important also was the fact that females, though less than males, was a considerable amount. Considerable number of female patients were there, and in that population, it has shown a better result.
yeah.
Similarly, the more severe the stroke, when NIH score is more than 10,
More than 10.
benefit is much more spectacular.
Yes, ma'am. In the altiplase group, it was
Carry on.
better. And internal carotid arteries, M1 segment of MCA and M2 segment of MCA.
No, but the confidence interval of that is, it was 1.14 to 3.96 for a severe stroke, and the p-value was 0.15, ma'am. Should we take it significant or like?
Relatively, when you see on this thing on the forest plot, that seems wider than the age of less than 80, no? So you will be more confident on practicing this algorithm in someone who's less than 80 years compared to those in more than 80-year group based on this.
Okay, ma'am.
But the numbers are too few to make any conclusive thing.
Yes.
But look at the time frame. You didn't talk much about time frame. Beware, this study's the most catch was the up to 24 hour result.
Yes, ma'am.
But then look, where the maximum benefit is in 4.5 to 9 hours. Beyond 9 hours, again, you're not very sure. The benefit is not so great.
Yeah, ma'am.
So,
Beyond 9 hours, on the next great on the unknown stroke onset time.
Similarly, when you go to site of occlusion, the larger vessel, this is not showing much benefit. It goes on to prove that if you have larger vessel occlusion, you should be doing thrombectomy. Out of thrombectomy is not a good idea. Look at it, crosses the line, no?
Yes, ma'am.
So it is not good. But when it comes to smaller vessels, M2 and beyond, there is definitely a positive effect.
Altiplase, but
the jinx of this study is in this forest plot. The whole of the result is very well put up in this.
Yeah, ma'am.
What's your take on the extracranial atherosclerosis?
Extracranial atherosclerosis, standard medical treatment has better.
Yeah, no role for altiplase here. It only shows some benefit in intracranial atherosclerosis. There is definitely a benefit there. Carry on. Carry on, Hari Prasad. Hariprasad, we've lost you.
Ma'am, just a minute, I'll call him back.
Sorry, ma'am.
Your screen is not shared with us right now.
Yeah, ma'am.
Yeah.
Sorry, ma'am. It got disconnected.
Carry on.
Ma'am, I'm going to discussion, ma'am.
Carry on.
The patients with stroke who had salvageable brain tissue and for whom endovascular thrombectomy was initially planned altiplase between 4.5 to 24 hours after stroke onset resulted in higher percentage of patients achieving a non-disabled functional outcome based on MRS scores compared with standard medical treatment. The secondary outcomes of functional independence, ordinal analysis of MRS and early neurological recovery provided supportive evidence for the benefit of altiplase. The incidence of symptomatic intracranial hemorrhage within the first 36 hours after randomization was higher in the altiplase group than in the standard treatment group. There was no difference in 90-day mortality between the two groups. And the limitations was it was an open label design, may have contributed to crossover between groups, bias in ascertaining outcomes. Patients with planned thrombectomy were excluded from the trial. The findings do not apply to use of bridging thrombolysis in the extended time window before planned thrombectomy. The findings may have limited applicability to population.
What is bridging
with-
thrombolysis?
Ma'am, bridging thrombolysis is once thrombolysis was done, the patient was taken up for mechanical thrombectomy or both, ma'am, with mechanical thrombectomy along with thrombolysis.
That is not bridging thrombolysis. That is the norm.
Okay, ma'am.
After thrombectomy, if you need to give, the perfusion is not good enough and you need to give again one more.
Yeah, ma'am.
You continue.
The findings may have limited applicability to populations with different stroke mechanism profiles. The administration of intravenous the administration of intravenous altiplase between 4.5 and 24 hours after stroke onset resulted in greater proportion of patients achieving a non-disabled functional outcome. After treatment, there was increase in symptomatic intracranial hemorrhage, but no significant difference in mortality. These findings support extending the therapeutic window for intravenous thrombolysis in appropriately selected patients when endovascular thrombectomy is not initially planned or indicated. And coming to critical appraisal, did the study address a clearly formulated research question? Yes, it was addressing the clearly formulated research question. Was the assignment of participants to interventions randomized? Yes. And were all the participants who were entered the study accounted for its conclusion? Yes. Were the participants blind to intervention? They were given no. It was an open label trial.
Wait. Were all the patients accounted for? What was one of the plus points of the study? There was no missing data.
Yeah, ma'am.
For the 90-day follow-up, there was no missing data.
No
That's
missing data.
very well performed.
Yeah, everybody was one. They were not in follow-up. They went to home and the investigators were.
How did they manage the 90-day follow-up without missing any data?
Ma'am,
There was also a telephonic.
ma'am, a telephonic thing was there, and in person they went to They went and assessed, it seems, I think so, ma'am.
What is the
92% was
importance of that?
telephonic interview, ma'am.
Yeah, what is the drawback of that telephonic?
They can't able to assess the,
There is an element of bias there.
yeah,
The interviewer being blind can be compromised when you're having a telephonic one. MRS, they cross-check with another investigator going and checking. That's
going
fine.
and see.
But the blinding may be compromised when there is a telephonic conversation. Continue.
Yeah. Were the investigators blind to the intervention they were giving to participants? No. Were the people assessing or analyzing outcomes blinded? Yes, ma'am. Were the study groups similar at the start of randomized control trial? Yes. And apart from the experimental intervention, did each study group receive the same level of care? That is where the treated equally? Yes. Can the results be applied to your local population or in your context? It is debatable. Maybe sometimes yes, ma'am. With the
Why do you say
experimental,
so?
no,
Why do you say so?
it was done in a set of population where only it was done in a single country, ma'am, China. So,
How should it matter?
ma'am, that's what, ma'am. I don't know, ma'am. Maybe sometimes can be
You're
applied.
questioning the ethical issues of the results, huh? No, single country does have a very big impact on the study. How?
Genetic influence.
Yes, the cause of the stroke may be very, very different. And
Yeah,
in fact, here the most of the causes were atherosclerotic. Cardioembolic were very less. Whereas what is your experience?
ma'am, in India also same, ma'am. It will be
Oh,
atherosclerotic is the
no,
most common.
we get more of cardioembolic, no? Almost
20%.
Yeah, ma'am, the predominant thing will be atherosclerotic.
Yeah.
we are getting more of cardioembolic. Every next patient will be having atrial fibrillation. The shower of emboli will be all over the place. There will be atherosclerosis with the carotid Doppler, but that may not be the disease. Anyway, we do have a significant number of cardioembolics. Exact results will not be reproducible in our cohort. It might be a little different. Yeah, carry on.
Would the experimental intervention provide greater value to the people in your care than any of the existing interventions? No. Do the benefits of the experimental intervention outweigh the harms and cost? Yes. Thank you.
So, what are you going to do based on this study in your practice? How is it going to affect your practice?
With ours is a tertiary care center, ma'am. Mostly will be going ahead with thrombectomy, ma'am.
Yeah, but someone is saying we don't want thrombectomy or the disease is beyond the large vessel.
Yeah, ma'am. Then we can go ahead with surely we can give a option of thrombolysis, ma'am.
In which, based on this study, which patients will you see? The selection of patient is very important based on this study. So, which will be the patient on whom you will select?
Ma'am,
Large vessel occlusion.
large vessel occlusion. Yeah, ma'am.
No,
We'll
wait.
select
I'm giving you a one scenario.
scenario. Okay,
So
ma'am.
the patient is large vessel occlusion, is come in the window period and doesn't want thrombectomy. Will you go ahead
Okay,
and with confidence tell them to undergo this?
ma'am, we'll do a imaging now based on CT perfusion imaging.
Will you take? Our results were very sketchy for the large vessel, no? In fact, in the forest plot, it crossed the vertical line, right?
Yeah,
Benefit
ma'am.
is minimal. That group thrombectomy is all that works. There's no point
Yeah,
of
ma'am.
doing this.
Point. Yeah, ma'am.
Whereas, if it is a severe stroke and it is beyond large vessel, we you may tell there is added risk, but some study in China has shown this. Would you want? You can give them the choice to make the decision.
Yeah.
But it is too preemptive right now to
Preemptive.
use
To
it in our
conclude.
subject. We'll need larger trials. But it
Yes,
is a very, very limited inclusion criteria, very selected patient only. So that makes its generalizability very skeptical.
Okay, ma'am.
Among the audience, anyone wants to ask any question? There is nothing on the chat box also.
Inactive place versus altiplace, ma'am. If suppose inactive place is available in the same
Come
sector population,
Hmm.
the same window period,
Hmm.
distal occlusion, severe stroke,
Hmm.
and there is a salvageable significant brain tissues.
Hmm.
Shall we adopt inactive place over altiplace, ma'am, in that case?
If you ask for evidence, we don't know. All the trials only have shown non-inferiority. Superiority of tenecteplase is not established. The
Okay.
ease of administration makes tenecteplase and its mechanism of action makes it more, it looks better.
Okay.
One is more comfortable using it, but it has not been proven that it is superior to altiplase. And this subgroup that they are talking about, there is no study comparing the two.
Okay. Possibly, if they can do another study, as you said, like for a stroke, severe stroke, with distal territory involvement, with a significant salvageable tissue, possibly they can compare altiplace and tenecteplase in that sector population.
Even before that, this very same question has to be studied in a redesigned fashion with multicentric, multinational study. Only
Yes,
then its general application
the
will
entire
be
applicability will be,
feasible.
yeah,
Yeah.
agree.
After that, then we can look at different drugs, altiplase versus tenecteplase. But this question, with this result, has to be looked up more in detail.
Yes, ma'am. Agreed, ma'am. But it's a very good trial, ma'am, actually. If you
Very
happen to
good, very
see.
good.
Yeah.
Yeah, very much need of the
Yes,
hour.
ma'am.
Okay, if no questions, Hariprasad, well done. Till we
Thank
meet
you.
again with another article. Good night.
Okay, ma'am.
See you
Thank you.
in a month.
Thank you, ma'am. Good night, ma'am.
Good night, ma'am. Good night. Thank you, ma'am. Thank you.
Okay.
Hola.